السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
يعطيكم العافية، مساء الخير جميعا. Thank you all for attending this session. وشكرا للشباب والزميلات القائمين على ساسم. الله يعطيكم العافية for your effort. My name is Dr. معاذ الشنقيطي. I'm an assistant consultant emergency medicine في مستشفى الحرس الوطني. I'm glad to have this session with all of you. Inshallah, today's session will be short, fun and interactive. We'll be talking about, inshallah, emergency presentation of belly secrets, emergencies that is related to abdominal emergencies. throughout the session. It will be interactive, inshallah. Feel free to ask any questions at any time. You can stop me, of course. I'll just arrange the session. Swap. Do you see my screen clearly?
Yes, Doctor.
طيب تمام. So today we'll be talking, inshallah, shortly, in brief, about emergencies that is related to abdominal system or the gastrointestinal system. We would like to recognize clinical feature and diagnosis that is related to the emergency department, since that we are talking about emergency medicine. We'll try to focus on red flags that should hit your brain when you think about, or when you are talking history or physical examination from a patient with gastrointestinal related emergency. We can differentiate also between surgical and non-surgical presentation that are time sensitive and the initial emergency approach related to these emergencies. There are a lot of emergency related presentation in the gastrointestinal system, but I tried my best to focus on the most important presentation, such as upper and lower GI bleeding, bowel obstruction, mesenteric ischemia, foreign bodies, and abdominal aortic aneurysm. There are some other emergency presentation related to the gastrointestinal system. Feel free to ask about them at any time. And if you have any questions, just raise your hand, stop me, open your mic, and we can stop and discuss whatever question that you have. So first of all, we're going to talk about upper GI bleed. Now, there are multiple causes of upper GI bleed. There are different between adults and pediatric. Most common cause that we can face in our emergency department is the peptic ulcer-related disease. And this can present in elderly and in young situations, specifically with the current lifestyle, consumption of caffeine, smoking, vaping, stress-related ulcers. All of this can produce an ulcer that can extend to a peptic ulcer and perforation and have a significant and life-threatening upper GI bleed. After that, we can have an erosive esophageal gastric varices, as we know, specifically in patients with liver disease, esophagitis, tears, miliary-wasted tears that are related to protective multiple episode of vomiting. You can have tear in your esophagus, and last of all, malignancy. It's a bit different in children. For sure, for you to have a peptic ulcer disease, you need a chronic stress, such as consumption of caffeine, consumption of an elderly patient, multiple medications. So the presentation in children usually is gastritis or miliary-wasted tear. Initially in the ER, when we have this presentation, when a patient having a history of upper GI bleed, we have to focus and take a detailed history from the patient to make sure that it's a truly blood with vomiting. So usually patients confuse coughing blood from having an upper GI bleed. Upper GI bleed is clearly having a color vomit with red presentation or a fresh blood. And once we have that, it's a high mortality presentation. We have to have CBC knowing the hemoglobin of the patient, coags, so we can know the coagulation status of the patient, type and screen, which means the blood group of the patient. So in case that we need to transfer blood to the patient, we'll be ready. And of course, related tests such as liver function test, troponin, because having a significant amount of bleed can cause stress in the heart and have elevated troponin. It can even extend of having an MI due to high volume of blood loss. And creatinine to check the kidney function test, because this is a volume loss situation. Does anyone know what's the difference between upper and lower GI bleed by definition? You can open your mic or write it in the text.
I can differentiate between them by the clinical presentation for the patient.
Okay. What else? So anatomically and by definition, as the Vincent said in the chat, it's the ligamentum of tear. So if it's proximal, that's gonna be upper, and distal it's gonna be Allahumma salli Muhammad, lower GI bleed. This is usually a question related in the exam. So how would we deal with this patient initially in the ED? So everything related to an ED presentation starts with an ABC, airway, breathing, and circulation. We have to make sure that the patient airway is secured, because this is an upper GI bleed that can interfere with the patient ventilation. If a patient is vomiting, he cannot breathe appropriately and he can aspirate. This blood can go into this patient's lung. We're gonna have a 2 set of IV cannulas to make sure that volume resuscitation is appropriate. This patient can have hypotension. We can have PPIs, which is short for such as esomeprazole, pantoprazole. This will decrease the gastric secretion, chloride secretion, and can help in assessing and reducing the amount of ulcer. And in a specific situations, such as liver-related presentations, we can have what's called octreotide. Now, octreotide will shift the blood from the esophagus to the spleen. So, though reducing the amount of bleeding in a situation with a liver disease is the most common cause of the upper GI bleed, not in peptic ulcer disease, in a liver disease. Okay, so patients with liver disease, they can have increasingly elevated portal circulation pressure, which can cause dilatation of the esophageal varices, which will lead to bleed. So octreotide will be used only in patients with liver disease to shift the blood toward the spleen. An antibiotic in cases of cirrhosis. Can we check the mic? نخلي بس المايك mute. So eventually we'll need a GI consult to do an endoscopy, either to look at this bleed or to cauterize this bleed or ligate it. So this is the end management result after appropriate resuscitation in the ED. Okay. So as I said, upper GI bleed is a high risk situation. If we check at the left side, your left in the screen, if there is a continuous bleeding, brisk, bright red, we have to do an ongoing resuscitation, as we said, with airway, breathing, and circulation, and emergent GI consultation for endoscopy. If that bleeding is not high risk, patient has stable vital signs, no massive bleeding, we have to use a risk stratification score that is called a Glasgow score, Glasgow-Blatchford score, to decide either to admit and discharge the patient, simply. Okay, so just to recap, upper GI bleed, it's a life-threatening condition. It can produce high mortality if it was not intervened and treated appropriately. And if a patient having a low risk, not hypotensive, vitally stable, not significant amount, they can be discharged after application of this score, as we said, which is called the Glasgow-Blatchford score. If you know MidCalc, the application, you're going to find it online there, and you can apply it for a patient coming with an upper with the GI bleed. نيجي نتكلم عن lower GI bleed. As we said, how did we differentiate between it and upper GI bleed? There are multiple causes. Among all, the most common going to be diverticulosis, angiodysplasia, colorectal cancer, and less commonly ischemic colitis. Usually the presentation will come with hematochezia, fresh blood, and sometimes melena. Okay, fresh blood is not usually specific only for lower GI bleed. If a patient have a significant upper GI bleed, active bleed, that fresh blood coming from the upper side of the body, if it's large amount, can overcome the abdomen and present as a lower GI bleed. So why this information is important, just keep in mind that when you evaluate a patient with hematochezia, fresh blood, you have to ask about symptoms of upper GI bleed. Usually they will have epigastric pain, vomiting of blood, but the most common presentation in hematochezia is lower GI bleed. Just keep this information in mind. When it comes to lower GI bleed, as we said, these are the causes, but it's different in pediatric with common sense. You need time and age to develop diverticulosis. In pediatric, usually it's anal fissure, Meckel diverticulum, or colitis simply, okay? Like, and it's different, as we said, in adult presentation. How are we going to evaluate it? Examination, rectal exam, doing a BR for the patient, or endoscopy to look if there is specific local cause. Sometimes hemorrhoids can have fresh blood or fissures. So if you visualize the local cause, you will be reassured. Different from having diverticulosis or malignancy or ischemic colitis. So the first thing is to rule out local causes. We're going to order CBC again to check the hemoglobin of the patient, coagulation the same way to check the coagulation status of the patient, type and cross to check the blood grouping of the patient in case that we need to deliver some blood. And in evaluation of lower GI bleed, we need to do CT angio. What does that mean? CT angio is a CT of the abdomen with contrast to check if there is any ischemia in the abdomen causing this presentation. So this is the sum up of a patient with a lower GI bleed. Again, high risk bleed, we're going to use stabilization, ABC, airway, breathing, and circulation. and CT to localize where is the bleeding is. And usually lower GI bleed, if they are significant, will be admitted to the ICU. If the patient is not high risk, what does that not mean? Stable vitals, not an elderly, bleeding source is seen, there is hemorrhoid, there is anal fissure at the verge. There is local cause, we're going to deal with it. Usually this patient can be discharged if they have hemorrhoids, local cause, anal fissures. If no, we have to admit the patient, and most likely we'll have a scope to localize the cause. Specifically, if this presentation is the first time. ما هو أحد who's known case of diverticulosis على سبيل المثال. So, do we have any questions until now regarding upper and lower GI bleed? Excellent. Right. So, second of all is bowel obstruction among the emergencies of related to the abdomen. What can you see here in the X-ray that is suggestive of bowel obstruction?
multiple air fluid level.
أهلا يا سوسن.
صلاح ما بيجي من بس صلاح ما بيحبش.
So multiple air fluid level, as you can see, that is suggestive of bowel obstruction. The higher the more the air fluid level, the higher the grade of the obstruction. In this situation, this is a high grade bowel obstruction, most likely in the small intestines. So the numbers is different. You cannot find a fixed number that would say this is a bowel obstruction yet. Generally speaking, 4 to 5 and more air fluid level is suggestive of bowel obstruction. Now, keep in mind that this is not very specific and sensitive for bowel obstruction. That is 50% sensitive. It's just like flipping a coin. If you don't have air fluid level, that does not mean there is no bowel obstruction. So we have to correlate it with the clinical picture. Other signs that we'd be looking for in the abdominal X-ray, which is not that common, you see this small valvular cavernous. This is the differentiate between small and large bowel obstruction. Usually you don't see it in a normal X-ray, but when there is significant dilatation of the bowel, you would see these fissures, which is part of the anatomy of the bowel, dilated. And this is suggestive of dilatation and can be suggestive of bowel obstruction. So, excellent. Importantly, in bowel obstruction, the previous history of the patient is extremely important because most patients do not have just acutely bowel obstruction of no cause. Usually there are some risk factors. For example, patient who has no malignancy, patient who did previous surgery before, multiple CS section, for example, a virgin abdomen that does not had surgery before, a bit unlikely to have a bowel obstruction of a mechanical cause. So abdominal pain, usually this presentation, will make it more suggestive if the patient has vomiting, that is projectile and bilious, because there is an obstruction pushing this fluid to be projectile. Constipation and obstipation. Constipation is what you know as constipation not passing stool, obstipation not passing air, okay? And rectal exam. So doing a BR for a patient, if there is a stool in the BR, that does not rule out or rule in, like if there is the clinical picture going with bowel obstruction and you did a BR and there is no stool, that would suggest more of bowel obstruction. Yet, usually the clinical presentation of bowel obstruction is accumulative. It's not only one thing. Before doing the CT, to confirm, clinical history, examination, adding to it an abdominal X-ray, for example, then the risk factor for the patient. And if you have high suspicion, you're going to do a CT to seek the cause of this bowel obstruction. Simple evaluation, usually we order chemistry panel, which include liver enzymes, creatinine. These patients usually are vomiting. Suspicion of ischemia with this obstruction will have high lactate, elevated white blood cells from the inflammation if the obstruction is prolonged. And lactate, as I said, can be led to bowel ischemia. So when a bowel is obstructed for a long time, it can go ischemic. And we evaluate it usually by starting off plain radiograph. After that, doing a CT to confirm the diagnosis and to look at the cause. There are questions regarding colonoscopy and enema, water-soluble enema, that patient can either have it as an enema or drink it, yet plain radiograph and CTs are enough to make the diagnosis. Colonoscopy has other causes and other utilities in the ED. So if you were asked how to diagnose, definitely bowel obstruction. So it's going to be CT. Diagnose it and to look at the cause. How we do management in the ED in bowel obstruction? It's an emergency presentation, so we're gonna surgically consult general surgery. Gonna give symptomatic management, pain, analgesia, and supportive, which include IV fluid if the patient is vomiting, analgesia, and replace any electrolyte that comes with the vomiting. Some suggest doing an NGT to decompress the abdomen, yet this is not an emergent intervention to do, and it has not been shown to be to change the patient outcome. You can elect to do it or not, or leave it to the general surgery to do it. Most importantly, in the ER, we have to replace the electrolytes, analgesia, IV fluid, and emergently push the patient to the OR. Any question regarding bowel obstruction? Which is the best X-ray for intestinal obstruction, spine or Crohn? So if we're talking about air fluid level, patient better to be sitting upright, so the level of the air will be up and the fluid will be down to differentiate. If the patient is lying flat, you can still having air fluid level, but upright X-ray would be more specific and sensitive to roll it. Or if the patient cannot sit upright, for example, an elderly, you can have a lateral decubitus. The patient will lay flat on the lateral side, and you're gonna have the image from the abdomen from the lateral side. You can see the fluid going down and the air is going up. Because someone is asking in the chat how to differentiate between them. Good. Third, we're going to talk about mesenteric ischemia. Now, mesenteric ischemia can have multiple presentations and multiple causes. It can be an arterial embolism or thrombosis. It can be non-occlusive mesenteric ischemia. For example, a patient who's having a significant amount of bleed from trauma, and that would reduce the blood flow to the abdomen, and they can develop ischemia. Or mesenteric venous thrombosis, just as similarly having a DVT of the abdomen, simply. Now, again, this is an emergency presentation because within 15 minutes of ischemia, if not corrected, the sludging will occur within 3 hours. After 6 hours, necrosis will be complete. So this is an emergency presentation that need to be intervened once you have suspicion and confirmation of mesenteric ischemia. How to evaluate it? The presentation of mesenteric ischemia is largely dependent on the cause. So venous, different from arterial, different from ischemic or hemorrhagic ischemia. The usual presentation, the usual word when you hear bowel ischemia is pain out of proportion. This can happen initially in the presentation when the blood flow is being reduced to the abdomen. Yet, when the blood flow is completely stopped and necrosis has started, patient can present without pain out of proportion. They can have simple generalized abdominal pain. Elderly patient can present without having pain out of proportion. What does pain out of proportion mean? So the patient is screaming out of pain, but when you palpate the abdomen, you cannot localize a specific pain site. You cannot produce the same amount of pain that correlate with the patient presentation. So there are no biomarkers, no specific tests in the lab to look at bowel ischemia. Yet usually because of the necrosis and the inflammation, they're gonna have white blood cells elevation, significantly elevated, and lactic acid. But not having white blood cells and lactic acid does not rule out bowel ischemia. Just keep this in mind. It's about the clinical presentation of the patient. Abdomen, usually emergency abdomen presentation, they are tricky. They rely largely on history, risk factors, and examination. Imaging will cut it short, but imaging can be different. We have to decide what type of image do we need. So we have to have a differential diagnosis for the patient before doing an image. Are we going to do CT abdomen with or without contrast? Are we going to do oral contrast? Are we going to do simple X-ray? So this highlights the importance of having excellent and appropriate history and physical examination. Obviously, CT angio will be the diagnostic tool because we want to look at the contrast going throughout the circulation to the abdomen. Simple X-rays, not specific, yet there are some findings. As you can see, I hope that you can see it clearly. And the arrow number 1, there is portal venous gas in the portal hepatics. I'm not sure if it's clear in your screen because having these findings in the X-ray is not that common. So I tried my best to find something that combined them all. So in the arrow number 1, when you get the presentation, there are gases inside the porta hepatics, portal circulation. In the arrow number 2, there is something called the mitosis intestinalis, which is air in the bowel itself, wall. And in arrow number 3, there are some bubble. Just bear with me, try to visualize it, or you can Google it while we are talking. But in the X-ray that is closer to me, we'll see it clear. And when you get the presentation, you can see it. So what are the signs of mesenteric ischemia on X-ray? It's either portal gases, nematosis intestinalis, which is air in the wall of the small intestines or large intestines, and bubbles that you can see in the wall of the intestines. And when you think about it, it makes sense. When there is ischemia, the wall of that part of the body will get necrotic, will get fragile, and they will have air in it and gonna have some bubbles in it because of this ischemia. Good. That's regard bowel ischemia. So this is the presentation of it. How we manage it. Once we diagnose it, it's emergency presentation to the OR. You gotta give analgesia and antibiotic if there is signs of infection, as we said, and the patient will be taken immediately to OR to relieve that ischemia. Any questions so far? Good. Now, foreign bodies. Foreign bodies are more common in the pediatric population because they are pediatric population and they like to explore everything around them and try to put everything in their mouth. It's not uncommon in the adult presentation, yet it's more common in the pediatric presentation. There are specific anatomical level that is important to us in the ER when we look at foreign bodies. Most commonly in the pediatric population, it's in the cricopharyngeus muscle. There is a narrowing. Foreign bodies will stick there. Where in adults, usually at the lower esophageal sphincter, when we are talking about esophageal foreign bodies. So in pediatric, in the cricopharyngeus muscle, and in adults, in the lower esophageal sphincter. Importantly, in patients with foreign bodies, to ask about what is the type of the foreign body and what is the time of ingestion, and we're going to talk about why time is important. Is it single or multiple? Did they ingest something else with it? And what are the causes? Is it psychiatric cause? Were they trying to, for example, we have something called buddy backers in our emergency society. That means people who try to smuggle unauthorized drugs throughout the airport or the checkpoint. What they usually do, they swallow some foreign bodies, which is a dangerous situation because these foreign bodies can perforate and cause these drugs into their bloodstream. So we have to know the cause. So this situation will not be repetitive. And we see it more commonly in the ER when patients are psychiatric patients. And this should be evaluated because this can happen again. Maybe this time is a simple foreign body. Maybe next time it's going to be something sharp will cause perforation or something that will cause necrosis to the abdomen when you talk about it. Initially, we're going to start by X-ray, okay? And ultrasound has a role in some foreign bodies, but X-ray will be more than enough to check if this foreign body is radiopaque. Can anyone tell me what's the difference between the two pictures? What is the location of the foreign body and why? Let's see in the chat. Left is trachea, right is esophagus. That's true, because for the foreign body to go through the trachea, as you know, you have to pass the vocal cord, right? On the left side when I'm pointing. And the right side, the esophagus, is just a circular muscle. So the trachea, in order for a foreign body to go through the bronchus into the lungs, if it's circular, it will be in this location. And it will be with this side because هو لازم يروح through the vocal cords فلازم يكون longitudinal in this situation على عكس الاسophagus. So this is how to differentiate between, okay? And this is important because a foreign body in the airway is more dangerous than a foreign body in the esophagus, specifically when you are talking about coins, okay? Good. Usual presentation, we're gonna have our ABC in a patient with a foreign body, airway, breathing, and circulation. In esophageal foreign body, an urgent intervention must be done for a patient who have bottom batteries, البطاريات اللي هي زي حقت الريموتات اللي تعرفوها الدائرية السيلكر هذه, because this will interact with the esophagus or the abdomen. Specifically, we're talking about the esophagus and will cause a chemical reaction and lead to perforation. So this is need to be removed emergently. Large or sharp objects, for example, we've seen patient with toothpicks, patient with needles in the esophagus, coins in the proximal esophagus. This can lead to obstruction and vomiting and aspiration. طيب, patient who cannot handle his secretions, بني آدم شرقان على حاجة على سبيل المثال, coming to the ED. This is an emergent intervention. And food boluses. We've seen patient with large amount of meat ولا fish ولا حتى عظمة سمك على سبيل المثال تكون lodged in a specific place that can lead eventually to esophageal obstruction. These things need to be removed within this time, 2 to 6 hours. Now, of course, if the patient is presenting in a life-threatening situation, you have to remove it now. Or intubate the patient to secure the airway, then talk about a foreign body. But in a patient who is more stable, urgent intervention with a scope to remove these foreign bodies can be done within 2 to 6 hours. Now, when we talk about stomach is a bit different, okay? Because you have to calculate the risk of benefit of removing a foreign body from the stomach. You can cause harm by doing a scope for everyone who comes with a foreign body. So they develop with a specific approach. Conservative outpatient management for majority of cases, except that object longer than 5 centimeter in long, أطول من 5 سنتي, ولا أعرض من نصها اللي هي 2.5 centimeter. This size was made because these objects unlikely to pass, and they're going to be stuck and they're going to cause bowel obstruction. All sharp objects can cause, اللهم صل محمد, pointed foreign bodies can cause perforation, better to be removed. Smaller objects, regardless of what they are, except things that can cause a chemical reaction, like batteries, can be observed, okay, up to 3 to 4 weeks with serial X-rays weekly. And usually these patients, pediatric patients, usually they are, we ask the family to monitor their stool and to bring them each week for abdominal X-ray if the foreign body is seen in the X-ray. Not all foreign bodies can be seen in the X-ray. يعني مو كل الأشياء راديو أوبيك تبان وتنور في الإكس-راي، بعضها ما تنور في الإكس-راي معنا. Only small foreign bodies can, there is a question, only small foreign bodies can pass the vocal cord and enter the trachea, right? Yeah, you need to have something that can pass through the vocal cord. For example, you cannot have something large like a ball, for example, that goes through the vocal cord. Usually small foreign bodies that can pass there. So as I said, that conservative management is preferred for a patient with abdominal stomach and large small bowel foreign bodies, except these foreign bodies that you can see in your screen. Lastly, I'm going to talk about abdominal aortic aneurysm. Abdominal aortic aneurysm is a life-threatening presentation if it's ruptured, and it's a silent killer. Once abdominal aortic aneurysm ruptures, that's it. There is pretty much nothing that you can do for the patient, and the mortality is almost as up as 90 to 100%, because we're talking about the abdominal aorta, and the significant amount of pressure and blood is there. So it's important to intervene with these patients before that abdominal aortic aneurysm has ruptured. Risk factors usually for this is atherosclerotic changes in the vessels of the body, vascular disease, Marfan syndrome, collagen diseases. Most commonly, and this is a screening tool, and if a patient has an abdominal aortic aneurysm or rupture, usually all of the family members, first degree relatives, should be scanned for abdominal aortic aneurysm because there is a huge genetic factors in it. We diagnose it usually by X-ray, ultrasound, and CT scan, and I'm going to tell you which one is better. X-ray is not specific in order for you to see an abdominal aortic aneurysm. If you can see on your left picture, picture number A, the middle is the vertebra. Right to the vertebra, your right, is an dilated abdominal aorta. And you can see it in the X-ray because this is an elderly patient, has some calcification in his aorta. Otherwise, you cannot see the abdominal aorta in the X-ray. So X-ray is not helpful in doing so. على عكس ultrasound, which is almost 100% specific for abdominal aneurysm, And this is what we usually do in the ED. Any patient that comes with a suspicion of abdominal aortic aneurysm, how do they present? Epigastric pain, flank pain, hypotension, for example, with no reason. We scan them with ultrasound in the ED. And we can see, as you can see in the middle of the screen, there is a black discoloration in the middle. Around it, this is a thrombus or hematoma has been formulated. That has been formulated due to the bleeding. Okay. Yes, 1 second. Let me mute. Guys, can you check the mic, please?
احسن ما نقدر حتى احسن ظني من في اديان صبح مكه تصوير شو بتشيل جدة اشرب جدة اشرب الله يسلمك ضرورة
We'll make everyone mute better, and we can talk in the chat. Thank you. So as I said, is abdominal ultrasound is been used to evaluate for abdominal aortic aneurysm. More specifically, and the end result to do is to do a CT. If the time is allows, we can do abdominal ultrasound to a patient who has a ruptured abdominal aneurysm at the bedside. But taking them to the CT and doing an abdominal CT with contrast is time consuming and the patient is unstable. If they rupture, they have minutes before they die, before you take them to the OR. As you can see in the middle, this is the abdominal aorta. I'm gonna make sure that my pointer is working. Just 1 second. As you can see, this, the abdominal aorta is dilated, obviously. And next to it, here to the right, this is a hematoma that has been performed due to that bleeding. And you can see it clearly, the amount of size. Now, this is large size. This is around 10 to 12 centimeters, which is a huge. The cutoff for abdominal aorta usually is around 3 centimeters. And we're going to talk about what's the difference between each cutoff. And this is ruptured. But a thrombus has been formed around it. That's, subhanAllah, yani, stop the active bleeding. But usually in the ED, we rely on this, on the ultrasound, and just push the patient to the OR. This is what's safe and better for the patient. Okay. So management is airway, breathing, circulation again, to make sure that the specifically circulation, we're going to give patient blood. BTX stands for blood transfusion, and immediately take them to the OR. We consult the vascular and take them to the OR, and they have to control the source of bleeding there. Yet, what if it's not ruptured, and we discovered that the patients only have abdominal aortic aneurysm? Yearly evaluation by ultrasound or CT to make sure that is not dilating in an inappropriate size. So as I told you before, this is an emergency presentation. Okay, so it's important that we evaluate this patient and discover them early on, or even operate on them if there is a high risk of rupture. Maybe, and let me check the chat. So this is the sum up of all abdominal related emergencies. And I hope that I tried my best to touch down only in things that are related in the emergency department and life-threatening and require an immediate intervention. Keep in mind, abdominal presentation is a struggle. Exam and history will make the huge difference in a patient. It's simple to just do CT for a patient and cut it short, yet the type and modality of the image that you need to do will rely on most likely the history and physical examination that you're going to do for the patient. If anyone have any questions related to the topic or related to emergency medicine in general, feel free to ask them. Can you repeat the common clinical presentation of ruptured abdominal aortic aneurysm? The usual presentation of a ruptured abdominal aneurysm is severe, significant epigastric abdominal pain or flank pain. Syncope can present with a ruptured abdominal aortic aneurysm because sudden rupture, you lose the blood and perfusion to the brain, and hypotension. Usually we see it in the ER with significant epigastric abdominal pain and sudden hypotension. And we do the ultrasound and you can see a ruptured abdominal aneurysm. Did you face a RIBOA for AAA? RIBOA has been out. For those who does not know what RIBOA means, RIBOA simply is inserting something similar to a central line into the femoral artery to occlude the bleeding or reduce the blood to a specific area. Now, in abdominal aortic aneurysm, it has not been used, لكن it can be used for specific situation in trauma. لكن هذا الكلام قديم جدا جدا. It's يعني حتى الكت ما تشوفه في أماكن كثير يعني. No one does RIBOA anymore. This is falls out like 20-30 years ago. We have better things that we can evaluate for taking a patient to OR. It's just better than doing a RIBOA because it's time consuming and does not really change the patient outcome. Any more questions? How we differentiate between tracheal and sure. Let's go back to that slide. So, as you can see on the left side, your left, this is a tracheal foreign body. I want you to imagine the vocal cord. For a foreign body to pass into the trachea, it has to pass through the vocal cord. ما حيقدر يجي بالعرض. ما حيقدر يجي بالطريقة هذه دائرية زي كده. لازم يجي بالعرض عشان يصير له باس throughout the trachea. لما يكون بالشكل هذا في الاكس راي هذا اكيد في الاسوفيجاس لانه الفوكال كورد جايه بالطول هنا زي كده. فاكرين ما اعرف اذا انا من جيل يعني مره قديم ولا لا، كان في زمان الات تحط فيها كان في آلات زمان تحط فيها نص ريال ويطلع لك حلاوة ولا لبان ولا واتس ايفر يعني، شكلها زي شكل الفوكال كورد عشان تحط النص ريال هذا الحديد فيها. ف in order to pass the trachea it has to be in this shape جاي بالعرض زي كذا. In the trachea, if the patient having someone is asking how to manage it in the trachea, if the patient is having airway disturbance and he's not stable, we're going to intubate the patient. Try to remove it, but we're not going to spend so much time on it. If we can visualize this, we can remove it. If we cannot, we're going to just intubate the patient and take the patient for bronchoscope with the pulmonary department or ENT to remove it. Any more questions?
الله يعطيك العافية دكتور.
طيب الله يعطيكم العافية يا رب و thank you so much for the invitation and the effort for making this presentation. دائما ما شاء الله عليكم يعني في ساسم متميزين. I'm trying to come up يعني ولا keep up with ما شاء الله your presentations and the things that you do. من كثرة ما شاء الله تبارك الله it's يعني it's something nice to see. It was my pleasure and inshallah we're gonna meet in the next presentation in the future بإذن الله تعالى.